It's a pleasure to be here. It's a pleasure to provide a little, perhaps different perspective on fetal monitoring. I have the clicker. Does the clicker work?
I think it's just me.
Before doing this, I want to pay just a moment of homage to Chris Redman. I make a distinction between courtesy and respect. Courtesy is something we owe each other. Respect, no matter what your title, is something you have to earn. And having earned respect, there is a greater prize involved, and that prize is affection. And if there's one person who has, in fact, deserves all three of those, it is Chris Redman. I want to talk a little bit about, and it's necessary to give you a disclosure, some disclosures, because I have no large databases, I have no university appointments, I have no research assistants, and no grants. The database I do have is there were 600 pristine intrapartum records with routine fetal monitoring using a scalp electrode, with routine scalp sampling, with routine umbilical cord analysis, and with routine analysis for the first hour of labor. We call those the Dead Sea Scrolls. I have also, because of involvement with medical malpractice, had the opportunity to review the complete records in perhaps 4 or more thousand babies who are neurologically handicapped, perhaps as a result of their intrapartum experience. I thought I had learned a lot in those 50 years of doing malpractice, only to find out my education was not yet complete when I was introduced well into my prime, as it will. I realized that this was the youngest that I am ever going to be. The fact is that I was introduced to 2 disorders. One was autism spectrum disorder, and the other was the allegation of child abuse in the newborn. I'm not an expert in autism, as I'll share with you. I'm not an expert in AI. I am not an AI evangelist, although I believe it is certainly the future. And for reasons I hope you'll understand, I make a distinction between being optimistic and being hopeful. I think I'll skip this for the time being. You'll recognize this as the as part of the publication from this organization last year. The point I was going to make is that I was glad to see the focus on other sources of injury other than hypoxia. I wish you'd mentioned head compression, but that's something we'll deal with. Clearly, we have to be talking about long-term outcomes because the neonatal period does not tell you everything about the long-term outcome. A word about cesarean sections. It's not, I would hope to convince you that we should not bother with the cesarean section rate, but what we need to do is make the section rates appropriate, and if there's one number you can drive to 0, theoretically, almost 0, that is the need for emergency cesarean section, the stat cesarean section. What I hope you will agree is that the amount of stat cesarean sections you do is related to the quality of the care that you are providing. Ultimately, AI, if it works, is going to have to do more than give progress notes. It's going to have to give a report about what it understood and what it understands is happening with labor and delivery. because that report, as I will try to show you, hopefully, is going to be important in a lot of people's lives. This is the biggest hallucination of them all. This is the New York Times magazine section. I think it was November of last year. It was entitled, "The Worst Test in Medicine is Driving America's High Cesarean Section Rate." Can anybody guess what that test is? The CTG. That was what she is talking about, the fetal monitor tracing, and the arguments are simple. It increases the cesarean section rate, perhaps as you've heard, operative delivery rates without benefit. It is a litigion. It is considered the linchpin for obstetrical litigation. Not only are patients not convinced that it works, but that there's a substantial portion of the people in the specialty who don't believe. And the question is, this classification, what you're after, what you're using fetal monitoring for, is it more to protect the fetus, or is it more to protect the baby? Could I convince you that the use of the term newborn is a hallucination? Could I get you to agree that the newborn is not new? Could I get you to agree that it comes to the neonatologist with a history that is not often used? If you ask neonatologists, do you use the information from the CTG, they will say no. If you transfer a baby from one hospital to another because of respiratory distress or neurologic injury, in how many hospitals does the CTG accompany the trip? And the answer is few, if any. We're making the baby, the newborn, an orphan. He's got more information that we should be paying attention to, and unfortunately, we are not. Can AI help? Absolutely. AI can help by keeping the fetus safe, not deciding how close you get to disaster before you intervene, but keeping the baby and the mother out of harm's way in the first place. And you can identify the need for neuroprotection because, as I shall try to convince you, you can make the diagnosis of neurologic injury irrespective of what the phenotype of the baby is at the time of delivery. And as I'll share with you, try to share with you, this information becomes potentially critically important in the assessment of the provenance and preventability of autism, and certainly the preventability of incarceration for the allegation of abusive head trauma. I'm sorry if it's 3 centimeters. I'm sorry. If you're used to looking at 1 or 2 or half or 3/4, this is 3 centimeters. And I am trying to convince you that this is not a baby with no hypoxia, even though all of you would agree to that. What I am trying to convince you of is this is normal physiologic behavior. This is a baby who sequences through quiet sleep, REM sleep, active sleep. It is a pattern that cannot be camouflaged. It can't be counterfeited. Can't be counterfeited. There's no way to make it happen without it happening spontaneously. Can you all see the same tracing? This is a baby who has no decelerations during labor. If anything, it has accelerations with uterine contractions, but you will see that the baby has absent variability. In the absence of drugs, in the absence of anomaly, this is an abnormal behavior. This baby under no circumstances is asphyxiated. That baby is been injured. The pH will be normal. Unless something changes, there will be no reason to interrupt its course in labor as long as progress is being made. But the notion that that baby is normal is not reasonable. I want to try to have you diagnose with me a stroke. What I hope you will see in the upper left corner is a stable heart rate, moderate variability, and all of a sudden, out of nowhere, with a divining rod, if you're going to predict it, you would need one. The baby has a prolonged deceleration on the upper right, and look what happens to the heart rate afterwards. The baby has been injured. The baby is not asphyxiated. There is no possibility that the initial tracing represents any asphyxial or compromised oxygen availability in any way, shape, or form. And out of the blue, is this an intrapartum injury? Yes. Is it preventable? Highly unlikely. I want to share with you a tracing, sorry about the 3 centimeters, in which you can see with the onset of pushing in the upper right-hand corner, there is a change in the character of the tracing. The baby develops decelerations. The baby continues those decelerations. They get worse and worse, and by the end, we have a profound bradycardia, and a stat cesarean section is performed. Could we have avoided the cesarean section? Probably. Perhaps not. Could we have avoided the stat part of it? Well, I submit that if we had had fewer contractions to start with, we had less compulsive pushing with those frequent contractions, we would have avoided the need. With this as a preamble, let me take you to a discovery we made. We had reviewed a patient with what we thought was an obvious obstetrical injury, and only to find in the follow-up records that all of the issues with the labor and delivery had disappeared from the medical record, and the baby was identified as autism, and an autism workup was conducted, and involving genetics, involving biochemical and metabolic workup with no positive results returning. And we thought this was very strange in that the diagnosis of all of those events of labor and delivery had disappeared. As you all know, autism is considered unpreventable. It's got a lot of causes, a lot of risk factors, genetics being the most interesting or frequent, environmental issues, and even perinatal issues. There are a number of reviews of perinatal issues as risk factors for the subsequent development of autism, none of which is considered actionable, none of which is considered actionable. The problem we had with the case, the initial case, was the notion that if you're going to have a problem as a newborn or as a baby, you're going to have if you're going to have a problem that's related to labor, it's going to have to be present at the time of birth. That was a universal understanding, appeared to be a universal understanding of all the people doing the evaluation for the subsequent diagnosis of autism. So we went back and looked, and we were able to find 40 patients who came to lawsuit. That lawsuit, under no circumstances, was predicated on the presence of autism. All of the allegations were perinatal in origin. There was no allegation that specifically related to the autism. Okay? So in each one of these patients, a genetic and metabolic And there were a whole host, as you would expect, in a number of babies who were neurologically injured. There were a whole host, and I'm going to come back to this issue of the change, the sustained change in the baby's variability by the end of the fetal monitor tracing. Cesarean section, very common, and including most of them in this group undertaken as a result of a perceived need to deliver the baby emergently. APGAR scores were low, but not seriously low, and these were the immediate findings: skull fracture, molding. Notice that of the 30, only 18 went to the NICU, only 4 got cooling, and several were diagnosed with HIE. Of the 30, only 24 had MRIs, of which 6 were normal, and you can see the findings in the others. In the short-term follow-up, almost all of them were given a neurologic diagnosis related to the events of labor and delivery. And what I'm trying to share with you is the question of the relationship between the understanding that some babies with autism have decreased variability and problems with autonomic responsiveness. And the question now is that loss of variability that was seen in these babies, okay, essentially the same mechanism of the decreased variability in later autism? And if that is the case, since most of these issues, most of the original injuries, we believe, were preventable, that opens the understanding for possibility not only understanding the provenance of some autism, but its ultimate prevention. I would ask you to take the same sequence, the lack of review of the obstetrical record, the assumption that a normal delivery, quote, normal delivery is normal, applies to allegations of child abuse. On child abuse panels, we've never encountered one that contains an obstetrician as part of the review committee. I thank you all for your attention, and I hope it provides a suggestion for activities of the future. Thank you very much.
Any questions?
Barry, thanks for that lovely presentation. Do you always see reduced variability following a stroke, or does it depend on the part of the brain that is stroked out?
If you lose the question relates to, does all neurologic injury affect variability and absent variability? The answer is no. Whoever mentioned seizures before or pathologic breathing, that can be associated with apparently normal variability. And depending upon where the injury is will depend upon whether you impact upon the variability of the tracing. But for all intents and purposes, that's kind of my argument is, it's not, this is about behavior, neurologic behavior, and what you are seeing in those flat heart rates, with or without decelerations, with or without accelerations, is an impaired parasympathetic nervous system, which is simply incapable of responding. That is why the decelerations become smaller, the rate goes up, the variability decreases, and while you see accelerations during contractions, that's sympathetic predominance. The other issue that I didn't talk about is in dealing with abnormal heart rate patterns in the second stage of labor, please push with every other contraction. Let the baby recover, and that's really, to me, the test of the physiologic, of the physiologic approach, is letting the baby recover for the stress. And remember, the question you're asking the baby is, how did you like that contraction? Let it recover.
Appreciate it, Barry. Thanks.
Question?
Yeah.
Very impressed to the autism is related to the hypoxia and ischemia. Did you find is there any data about MRI, brain MRI in the
MRI, and
Yes.
we have MRIs on these babies. Some are related, some are hemorrhagic. There were 4 subgaleal hemorrhages. There were 3 strokes. There seems to be a movement that stroke is somehow different from what we call hypoxic ischemic encephalopathy. It's our experience that they come from the same.
I believe if the hypoxia ischemia, the most vulnerable area is basal ganglia and the thalamus. I think these data is not correlated to the hypoxia ischemia. Is it? How do you think?
As a matter of fact, what I'm trying to suggest is they aren't. What I'm trying to suggest is, and there's a great deal of evidence, I would refer you to Annie Johnson from Sweden, who did this very nice study showing that the pH was irrelevant if you had neonatal encephalopathy, that the outcomes were the same whether you had a low pH or a normal pH. What she did show was that the babies who came in with abnormal heart rate patterns had essentially the same risk of neurologic injury as those who developed injury during labor. So I think that that hypoxia is not the answer, or it's not going to be the answer. I think that behavior, the neurologic behavioral interrogation of the baby will answer the problems of whether the mechanism of this change is hypoxia or ischemia, separate from hypoxia, and that is where most of the injury occurs.
Okay, I'll make it quick. So I think cerebellum might be another option to evaluate regarding the association of autism and these brain injury. I'm not telling it's related to labor or not, but these region injury might be related to cerebellum as well. And then cerebellar injury is known to be associated with autism. Then these are relation to each other. So these injury might cause cerebellar injury later on.
We didn't look specifically for that, but one of the statistics was the high order of, I think, over a third of them, of the babies are occiput posterior. And we discussed briefly the possibility that that is related or preferentially related to cerebellar injury.
May I ask for more questions to be maybe put in lunchtime? We have enough time for a long lunchtime, if that's okay. And I'm sure that you would entertain questions.
I didn't want to go
okay.
over, sorry. There were always more slides, and I can always...
it's a half century of experience that we're hearing here, so I think it was worth it.
It's mandibular fibrillation.
Thank you, Bill.